This podcast is for general informational educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients.
Welcome, everybody, to another episode of PHM from Pittsburgh. I am still your host, Dr. Tony Tarchichi. As you all know, I'm a MedPeds trained pediatric hospitalist here at UPMC Children's Hospital, Pittsburgh, in the Paul C. Gaffney Division of Pediatric Hospital Medicine. If you're new to the show, welcome. If you're regulars, welcome back. We've been getting together since October of 2016, which is getting farther and farther away. We're actually zeroing in our 100th episode special, which is going to be remarkable that we've gotten this far, this long. And we are here today covering one of the topics in the content specifications, and this is a little bit special. Now, we've done these episodes every once in a while. We are partnering with the American Academy of Pediatrics section on hospital medicine, subsection for newborn medicine. So special shout out and thanks Dr. Julie Kim for helping to put this together. But this is a partnered episode with our newborn hospitalist specialist. And how this came about, if you went to PHM, which you know I did, we did our episode from there. There's this fantastic talk on Ankyloglossia. I did not go to that talk. Dr. Julie Kim did. And our special guest today was the one giving the talk and was so floored by how great this whole session was. Emailed me because Julie knows me well. And so you got to have her on the show. And I completely agreed. So without further ado, our topic today, we're going to be covering the clinical report, identification and management of Ankyloglossia and its effect on breastfeeding in infants, AAP clinical report, published in Pediatrics 2024, issue 154. And the authors are Dr. Jennifer Thomas, Dr. Maya Bunick, Dr. Allison Holmes, who we've had in the show before, et al. And we are fortunate enough to have the first author, Dr. Jenny Thomas. Dr. Thomas is a pediatrician and breastfeeding medicine specialist in Milwaukee, Wisconsin, with Advocate Children's Health. She serves on the American Academy of Pediatrics section on breastfeeding leadership team and serves as the chapter breastfeeding champion for the Wisconsin chapter of the AAP. She's recognized as a fellow of the Academy of Breastfeeding Medicine for her expertise on breastfeeding, and she was an international board-certified lactation consultant for 20 years and was in the first group of physicians in the U.S. and Canada to be board-certified in breastfeeding and lactation medicine. She is the AAP liaison to the American Academy of Pediatric Dentistry Frenectomy Work Group. So there's nobody better to talk about this topic than our guest. So Dr. Thomas, thank you for joining us.
Yeah, thanks for the invitation. That's very nice.
So Jenny, now we have to do our disclosures. This is a CME podcast. I will go first and kick it out to you. I was on the Sanofi Corporation's advisory board for increasing a vaccination rate in immunocompromised patients. And you're up.
I don't have anything to disclose.
All right. Now that that's done, so Jenny, I always like to ask before we start any clinical reports or new guidelines, how long was this in the works? Because I don't think people realize how long these things take to get published.
I was trying to remember when we got the ball rolling, and I think it was late in 2015. It may have been 2016. It's been a long time though in the process. The AAP's guideline. So it was supposed to be a policy statement first, and then the AAP took a look at the available research and said that it just was not going to stand up to policy statement levels of evidence. And so they switched it over to a clinical report. But it was an ELF resolution, actually, at the annual leadership forum for the AAP, where pediatricians had sort of sounded the alarm on the increasing amount of frenectomies that were being done on their patients. And this sort of came out of that ELF resolution as well.
Well, it's nice to see that these types of things with the AAP, from idea to people noticing to a statement, clinical report, it does take 8 to 9 years. This is not an easy thing to do, especially for the first author, such as yourself. So we're going to dive right in. So the first thing the clinical report talks about is the AAP recommending exclusive breastfeeding for about 6 months with continued breastfeeding for 2 years or longer as mutually desired by the mother and infant. And that is kind of like the intro, which is a nice thing to review. Then it talks about ankyloglossia. And what you guys say is a condition present at birth that restricts the tongue's range of motion because of a short or tight band of tissue called the lingual frenulum, which tethers the bottom of the tongue's tip to the floor of the mouth. Now, and then right away, I found this interesting. There is no uniformed accepted diagnostic criteria for its diagnosis, ankyloglossia.
There's just really, that makes it really hard to do a clinical report on ankyloglossia when there's no really accepted definition. And we talk in the report also, there's a lot of scoring systems that have been used in the literature that have never been validated, and they're not reliable. So we went through in the report, there's just a lot of different scoring systems and lots of papers based on that scoring system. And it's really frustrating to be able to try to come up with a recommendation for how to make a diagnosis when we really don't have any validated or reliable scoring systems. The other part of the diagnosis is that it's a breastfeeding diagnosis, which means that there is a mom involved. And the focus about ankyloglossia has been so laser focused on the oral cavity, if you will, that it sort of ignores the fact that this is a functional diagnosis and it involves two people working together. And so that's one of the things that we really wanted to get across, is that if we're going to be evaluating for ankyloglossia in the setting of breastfeeding, that we have to observe a breastfeeding, and that maybe those scoring systems, even though they're not reliable or valid, maybe we shouldn't be using them, because we have to be looking at the complete package, the whole mom-baby diet.
So you're saying irrespective of what the tongue may or may not look like, you got to look at both sides, the mother and the baby. If it's
how they function together, right?
Yeah.
And so I've run into a couple of situations clinically where the baby is, 7 pounds and mom's nipple is the size of a golf ball. And it doesn't matter what that baby's tongue is able to do, that nipple's never going to fit in that baby's mouth when they're that little. And so if we would only be looking at the baby, there may be some decisions made. But when you put mom and baby together, then, if that nipple is too big, then we're going to have to do things to support mom's milk supply while the baby grows so that they can eventually breastfeed. And I've done observations of feedings in the hospital and in my office where the moms will tell me that I'm the first person who's actually looked at her exam in addition to the babies. And we're really trying to get that to stop happening. Like, if we are doing an exam, it's got to be mom and baby together. And if people don't feel comfortable doing that, then we have to establish a team. Healthcare is a team sport. Mm-hmm. We got to get the people around us that we trust to be able to do those complete assessments, so that we aren't sort of just focusing on one part of the exam and we're looking at the dyad together.
It's remarkable. It's what strikes me all the time is it's always the simplest solution. First, having a uniform definition of a subject usually makes it easier to talk about the subject. And second of all, when you have a baby and a mother and one is feeding the other, you should look at both.
It feels like we talk about this in the clinical report. We really got to a definition of pathology before we got to the definition of what's normal. So there's been a lot of pathologizing things that are probably normal, right? And so there was definitions of tongue restrictions and definitions of lip movement that sort of made pathology before we understood the physiology. Like, there's not a lot of good research on the latch. And when we started to actually do research on the latch, there is a range of what is normal, but the focus on the tongue and the lip got to be pathology before we even understood what they were supposed to be doing. So people will talk about how much the lip needs to evert. And really, I've been able to latch babies with cleft lips. And so what it looks like from MRI imaging and from what we understand the physiology of the latch to be is that the lip just has to create a seal, that it doesn't have to flip up or flange or whatever else people are trying to ascribe to it. And then that makes a procedure to do the lip not important, right? So that procedure got way ahead of what we understood normal to be and what physiology was supposed to look like. And then when we actually took a look at it, there really isn't a reason to have a lip do a lot of stuff. And so in our report, we said it's a normal oral structure. We should leave it alone.
Now, we're gonna ride this wave, because the first thing, what you said when I read that, I remember I was in residency in New Jersey. We went to Morristown Hospital, and there was this great breastfeeding specialist who showed us a video. It's the first time I ever saw this, and you guys talk about it in the guidelines that the physiology of breastfeeding is the nipple goes into the mouth of the baby. There's a vacuum seal created. The tongue pushes the nipple to the roof of the mouth, and like a drop of milk goes in. Is that an accurate way of describing
right.
that?
So there was again, we just did not have this research available to us. And so people were saying that there was a peristaltic movement of the tongue, or that the tongue was stripping the nipple.
I remember that.
It's the creation of a vacuum. So the tongue needs to elevate. I know when I learned about tongue tie a million years ago, it was just that the tongue had to extend, but the tongue has to be able to elevate. It compresses the nipple to the hard palate. And then when the tongue comes down, it creates a vacuum. And that is what transfers milk from the nipple to the baby. And so being able to extend and elevate the tongue is what needs to happen, but it's not a stripping action. It is a vacuum creation that does that.
And now, this wasn't what we had planned to talk about right now, but is it the vacuum seal that when the tongue goes down, is that what the mother, you think, feels when she says, I feel let down, or is it, you think it's just the actual milk leaving the breast?
The letdown is more the oxytocin release, and some women will they will feel like a pins and needles sensation. The letdown happens, and I can't say letdown. How many new mothers want to have a letdown? So the milk ejection reflex happens sometimes multiple times in a feeding, and not all women actually experience that. But it's the latch that causes the pain, right? And so the nipple is one of the most innervated organs in the body, and it's done as sort of a warning system that the baby isn't on correctly, and that if the tongue is in the wrong position and it is hitting the nipple, or is too short, so that it's hitting the end of the nipple, that should tell us that we need to readjust the latch and take a look at the latch. And if people are not comfortable doing that, assembling a team of people that know how to assess the latch is the important part. And to the mom with the big nipple, the kid is only going to hit the edge of the nipple, and it's going to be very painful. One of the things that you'll see if the tongue is in the wrong position is that the nipple, when the baby comes off, looks like a brand new lipstick. And so there's compression of the end of the nipple, and that is just not supposed to happen. The tongue is supposed to get completely under the nipple and not compress the end of it. So, but pain is a great indicator that the latch is not great. And so then we have to adjust and see if we can make that better.
Now, we're talking about a lot of anatomy. You guys go into anatomy and embryology in this guideline. And this is an area I read over and wrote out notes, but it's tough. It was tough for me to fully get it. I can
try. How about this? I can try.
Okay.
In the beginning part of the tongue-tied discussions online, the lingual frenulum, so the connective tissue underneath the tongue, was described as a separate structure that was a midline defect. So that is what they were talking about 10 or 15 years ago, was that maybe it had to do with folate supplementation because it was a midline defect. I don't know where a lot of that came from because we didn't have any of the anatomical studies. And then Nikki Mills, who is an otorhinolaryngologist, an ORL, they're not ENTs, they're ORLs in New Zealand. She did some anatomy and found that it's not a separate structure. It is actually the fascia of the floor of the mouth, and that it goes from one jaw to the other and is sort of lined up. And then where it connects to the ventral surface of the tongue, that is where we get ankyloglossia from. If that connection is to the end of the tip, the distal tip of the tongue, then that tongue's not going to elevate and it's not going to extend, and we're going to get pain with feeding and probably ineffective milk transfer. But that anatomy that lingual frenulum is found in 99% of people. It is a normal finding. if you pull up on the tongue to do an exam, you will see that everybody's got a frenulum. And because it exists in everybody, it's very tempting to make it pathology in everybody. But we have to see whether or not the tongue can elevate and extend, and whether or not there's any maternal anatomy that makes it a little bit more difficult for the baby to latch.
Now, that's remarkable. In the past 10 to 15 years, we have learned the structure and function of one of the most thought about things in the body, the tongue. I mean, they're going back to the beginning of medicine. The tongue has been outlined and looked at, and we're just discovering this stuff. It's fascinating.
The labial frenulum is a little bit different, and
Okay.
we don't think that the lingual frenulum changes much over time. The labial frenulum is very thick and can exist into the upper alveolar ridge. But as time goes on, we've got research that shows that the labial frenulum recedes over time, and that what it looks like in an infant is not going to predict what it looks like when kids get older. And the scoring systems, again, none of which are validated or reliable, but the scoring systems will talk about how thick it is and where it attaches. And that just is not a permanent finding. It changes over time. So again, because of the changing nature of the labial frenulum, we have not recommended any intervention for the lip.
And this isn't just, I mean, this is everyone. So the AAO, basically the American Academy of ENT, couldn't reach an agreement on what ankyloglossia is or posterior ankyloglossia, which you guys talk about throwing out altogether. And you all define something called symptomatic ankyloglossia. So that's basically a tongue tie or a tight lingual frenulum with breastfeeding difficulties that do not improve with lactation support.
Right. Yeah, that's what we decided to call that.
And then the other factors that play a role in symptomatic ankyloglossia is abnormal oral anatomy, infant suckling ability, and maternal breast anatomy. Like you're talking about, a very, very large nipple and a small mouth may not work together well.
Right. So when we talk about the team approach, where if people are not, like, people don't have to have my training to be supportive of breastfeeding families, but really we want to have a team of people with complementary skill sets that are going to be able to look at and help a breastfeeding dyad. So my favorite example is Maya Bunik, who's the second author and a breastfeeding medicine and pediatrician doc at Colorado Children's. She does a trifecta approach where she sees babies with feeding problems as a breastfeeding medicine specialist, and then she brings on an IBCLC, and she's got a psychologist who will see all of those patients to make sure that we are covering the whole mom baby dyad, and that we aren't just addressing the oral anatomy. Like, we are working together to make sure that all of the mom baby needs are met.
That sounds like the ideal setup, and that's a lot. That's a lot of resources.
Yes, it's wonderful, and they have an ENT that's available during that clinic. So if they need a tongue tie release, that they have somebody that is available at the same time. It's just a great program.
Now, Jenny, we've kind of touched on this, but I want to get into the epidemiology because you guys talk about that a lot. The diagnosis ranges, depending on the article, of ankyloglossia from 1.7 to 10.7%. And this was studies done in the U.S., Canada, and England. So for the American Academy of Pediatrics, that these are places that have a similar health system ours. Some would argue better, but we're not going to get into that. And then you talked about the inpatient databases from Walsh and Benoit and Way et al. To evaluate the incidence of ankyloglossia diagnosis and then performance of lingual frenotomies over time in the U.S. And they reported a 10-fold increase in the diagnosis of ankyloglossia between 1997 and 2012, and then another doubling between 2012 and 2016. And the graph you put in the guidelines, it's like a hockey stick. It's almost going straight up.
Yeah, it is. There's been, and those are just, so again, we're going to have an issue because we don't have a standardized definition of ankyloglossia. We don't have a reliable or validated screening tool. And some of the people that are doing frenotomies are not billing insurance, and there really isn't any way to capture how many they're doing. And so these are just the ones that we like they can report in the literature, but there are probably many more, obviously many more that are taking place that we're unaware of. But anytime you see a spike in something like that, whether it be like lead or an infectious disease, that it deserves investigation. And that is, one of the larger reasons that this clinical report came around. The incidence is really hard to define, and the studies of the incidence have been really early on, but again, probably filled with problems because we don't have a definition or a scoring system.
Yeah, I mean, if anything, this is just guessing on my part, so those listening, we don't have data for this, but once there's an agreed upon definition, my suspicion is the numbers will go up. But you're right. You guys talk about this group of physicians that are doing frenotomies outside of insurance for cash, and it makes it difficult to capture how many are being done. And then you actually bring up that Medicaid will cover pediatric ENTs to do this, so families, even if they're Medicaid insurance, don't need to pay cash. They can just wait and see a pediatric ENT, which I thought was a very nice thing to add.
Yeah, we have a lot of inequity. We just have a lot of disparities in breastfeeding promotion and access to breastfeeding support. And having a procedure that is several $100s is really out of the reach. And if this is a necessary procedure, which it absolutely is in some kids, it should be available to everyone and not just those people who can pay really expensive prices. We also think that there really needs to be some kind of financial disincentive to be doing this procedure. If we take away the financial incentive for this, that we will see that these procedures go down in incidence.
I think that's a fair thing to say. I think anytime you add, I mean, it's just been discovered in business and in everything. Once you have to financially incentivize the right things, or people will do the not right things if you financially incentivize it. I mean, that's our whole housing crash in 2008. But for those listening who are educators, if you have trainees, the figure 2 in this paper, Jenny, I loved figure 2 because it really was a nice picture of what you mean when you say ankyloglossia. It's really well done. And I haven't seen as good a figure to show trainees, I don't think, ever. So that was wonderful.
Thank you. Yeah.
Now, we've talked about the epidemiology. We've talked about symptomatic ankyloglossy. I'm just kind of looking to see where we are in our notes. Talked about breastfeeding difficulties. Now, you did bring up in the post, this paper seemed like, and tell me if I'm wrong here, if I'm reading into it, it was really meant for the postpartum period. So a baby is born, they're still in a newborn nursery, the mother hasn't been discharged, because a lot of it seems to talk about the postpartum period. Like, for instance, here you mentioned breastfeeding difficulties are common in the postpartum period. Nipple pain and a poor ineffective latch are among the most common complaints of breastfeeding mothers, but they don't necessarily mean symptomatic ankyloglossia. When you guys were doing this paper, was that a major thing you were looking at? The postpartum period, still in a newborn nursery, mother breastfeeding or a breastfeeding person with the pain, what should we recommend for physicians?
Well, so the latest breastfeeding report card for the Centers for Disease Control has said that it's somewhere around 84% of all mothers who deliver in the United States intend to breastfeed. And many of those people don't make it. Many of those moms don't make it to their intended breastfeeding goals. And there's a wide variety of reasons for that. But we have to establish breastfeeding because we don't get to start breastfeeding at 2 weeks, right? We have to make sure that it starts off well and that moms have some self-efficacy in their feeding. And so breastfeeding has to go well in the newborn period. It also has to go well in the first week. It's got to go well in the first 2 weeks. I spend a lot of time in the first 2 weeks advocating for breastfeeding families and making sure that they get the support that they need. But obviously, we want them to start off in the hospital getting all of the support that they can. There is a pretty big drop off in breastfeeding support from the newborn hospital period to the first outpatient visit. And that is one of the things that we know as a country we don't do very well, is to make sure that there is a continuity of services that happen in the hospital, that families can access hospital services as outpatients as well. We were asked to give a time frame as to when like, should you wait a week before making a diagnosis of tongue tie? And there, we could not come to a consensus. I think if I see a tongue that is distally attached, the baby's tongue won't elevate, or it's asymmetrically elevating because the central part of the tongue can't elevate, that should just be taken care of whenever that needs to be taken care of. Sore nipples are it happens to most families. Most women will experience sore nipples in the first 10 days, and trying to figure out the difference between a poor latch and a tongue tie is something that, like, skilled professionals need to be taking a look at. The contour of the breast changes from the newborn period to day 4 or day 5, and it changes again at day 7 or 8 when mom has peed off all of her IV fluids and the fluids that she retained at the end of pregnancy. And so sometimes the sore nipples that exist on day 4 will not happen at day 8, and you have to use a clinical judgment for that. But certainly, if there is a concern for a tongue tie in the first 48 hours or 72 hours, however long the baby's in the hospital, we did not say that should not be addressed. Like, you can go ahead and fix that. And if there's a distally attached tie, I will do it right in the newborn period. But we have to be really good advocates for families in the newborn period, because establishing the milk supply is going to be crucial. And so if we've sort of, I guess, symptomatic tie is that we've looked at this, we've tried to adjust the latch. We have a team of people who've been addressing all of the different issues. And if it's just really not getting any better, then it's reasonable to offer that procedure to the families. But there isn't any recommended time frame in which to do that.
Now, that's a perfect segue into your all's next section in the paper, which is pediatricians' role in diagnosing ankyloglossia. Which you're setting me up beautifully here. So what you talk about first is pediatricians considering if they're considering ankyloglossia causing breastfeeding difficulty, especially in infants with insufficient growth. And as a sidebar, that's where I see the kids. So I am at Children's Hospital of Pittsburgh. I don't do newborn hospital medicine. So those kids will come into us a week or two later after birth when there's been growth issues, and then we'll admit them to see what's going on. That's when I see them primarily. But you mentioned the first thing to do is review the history. Prenatal history, intra and postpartum period, including medications giving, any breastfeeding history with the mother, breast surgeries, breast and nipple anatomy, and then family history. So that's the first thing. And then continuing on history, infant feeding history, abnormal things like coughing, choking, color change, bilious emesis, easy fatigability, and then nipple trauma, nipple pain, long feeding times, difficulty staying attached. So basically, we're going down, as we always do in pediatrics or in medicine in general, history first, then physical. That's the first part of what a good physician will do, is taking care of a breastfeeding person and the baby, especially if there's weight gain issues. And then a full exam. And you're looking for things that would seem obvious to look for, but I just love that it was mentioned. So micro and retrognathia, cleft lip or cleft palate, which means gloving up the hand and putting the finger in the mouth to feel for it. Appearance of a lingual frenulum, including the ability of the infant to extend the tongue over the lower alveolar ridge, or lift the tongue midway to the palate, or a harp-shaped tongue extension. Those were great examples because it's sometimes difficult for me to describe to learners what exactly I'm looking for. I'm looking in the mouth, and that is clear as day what you should be looking for with the tongue. Did I miss anything there on the exam?
No, I think what we were trying to say through this whole thing is that we need a team approach, and really that team approach needs to start at the medical home, and that somebody needs to be the person that assembles the Avengers, so to speak. But that we as a team, when we were writing this, we're getting stories from families. And this is my personal story, but I had a child who's not in my practice, but came to see me as a consult and had a lingual frenotomy, and then went back and had another one because the feeding didn't improve. And the kid had a really big VSD and wasn't gaining weight because there was a heart lesion. And it really has to take place in the medical home so that we are addressing the whole baby and the whole biopsychosocial, wherever that family is. And it got to be where somebody said, it looks like it's the tongue. They went to a dentist who lasered it. And then when the feeding didn't get any, or the growth didn't get any better, they went back to the dentist instead of coming to the medical home. And we're not trying to say that pediatricians are the best at breastfeeding assessment, because we're not. We've got some room to grow.
Sure.
But also, even if we don't have that skill set, we can assemble a team, and we are very good at evaluating why babies don't grow. So we might not be very specific about the breastfeeding part of it, and we are working hard to improve that. But we are very good at trying to figure out if it's kidney disease or liver disease, or if there's a cleft palate. Like, there are things that pediatricians need to be involved in. And we really want the families, it's hard. You go from the hospital, and there are a lot of people who are helping you in the hospital, and then you get discharged, and it's hard to know who that phone call goes to. Do you try to call the hospital again? Do you call your OB's office? Do you call a pediatrician? And we've been saying that breastfeeding problems, even if the pediatrician isn't great at breastfeeding support, because I heard this at Peds Hospital Medicine over and over again, pediatricians are terrible at breastfeeding support. Even if we are terrible and we are working on improving it, that phone call should still go to the medical home so that the whole family can be looked at.
Now, I love talking to you. Bring up so many points. We can just veer off here now. Do you, in your opinion, since we talked about in your intro, this new breastfeeding with a board certification, do you think that's going to help? Because I know pediatricians, we've had Dr. Carly Safe here on, shout out to her, and she's got the certification. Now, do you think she also went into the whole training to learn this as well? And I know people that are interested in getting it and actively working to get it. Do you think that would help?
Oh, yeah, I think so. We have a new breastfeeding curriculum through the section on breastfeeding that is meant to be done in sort of a longitudinal fashion through residencies. We had a curriculum before that was sort of didactic and sort of meant to be sort of a one-time thing. But this is learning across the spectrum of your residency, because it is, I know we talk a lot about newborn breastfeeding, but like 6-month-olds still breastfeed and 2-year-olds still breastfeed. And so being able to have those discussions with families, and I'm a general pediatrician first and foremost, but I can incorporate breastfeeding guidance into every one of my visits. And even just if it's to give moms a pat on the back for making it so far in the United States, where we only get like a 7-second maternity leave. But there, I think in some specialties, like a newborn hospitalist, it makes a lot of sense to get extra training. And the section on breastfeeding can help with that. We've got a breastfeeding handbook for physicians. The section on breastfeeding's got a very active listserv. The Academy of Breastfeeding Medicine was life-changing for me when I first started in lactation, at the turn of the century. And so there are organizations that really are interested in focusing on physician education and breastfeeding. And it makes a lot of sense for newborn hospitalists to get that extra training. One of the criticisms that happened after the policy was released and aimed a lot at me was that pediatricians don't know how to do an oral motor skill assessment. And I don't know that we need to be able to do that. We need to be able to call on the speech therapists, the myofascial therapists, the lactation consultants, and all bring our services to the help of that family. But I also think that we can learn very quickly what it's supposed to look like when we're evaluating a latch, and that if people want to do that, there's a lot of us who want to help.
Yeah, I mean, I couldn't agree more. I think it will help. And I will tell you, you're right. It's a team effort. Where we are in Pittsburgh, in Children's Hospital Pittsburgh, we have fantastic lactation consultants that we will call on. And I'm shouting out to them, and without exaggerating, I have never had a family see them and not rave about our lactation consultants. And then, of course, our feeding team, which is our speech PT and OT, will come and see the patient as well and really do a comprehensive exam. But that's what I love about this part of the guideline, because then once you guys talk about the history and the physical, really reviewing what we should be looking for, you then give a differential diagnosis for ineffective feeding or poor growth, which includes, like you said, congenital heart disease, congenital adrenal hyperplasia, inborn errors in metabolism, which people sometimes will forget about, especially our trainees, intestinal obstruction, which is a really nice review. Whether you're a family doctor, a pediatrician, nurse practitioner, or a PA seeing infants, that in and of itself, I love that part of the guideline, because it kind of goes over everything you as the practitioner are looking for and what you should be thinking about.
Yeah. And again, we really wanted to pull the evaluation of the breastfeeding mom and baby away from just the mouth and really sort of considering that there are other things that might be going on.
We talked about the tools, that they're just nothing is validated. Then the treatment for symptomatic ankyloglossia. You brought up the dentists with the laser. I was surprised by that. I have to tell you, I did not know dentistry got involved at all, honestly. And then that they used the laser, I didn't know that happened. So that was all news to me. I knew about the scissors, and our ENT team for us at Pittsburgh. If we have a child admitted who we think needs a frenotomy, we will call Peds ENT because we're inpatient. Peds ENT is right there. They come and evaluate the patient. So that was interesting.
Yeah, there are a lot of dentists. There's several in Milwaukee that don't do dentistry anymore. They just do tongues and lips and buccal ties. And there's some concern there because they don't have a chart. They don't have a growth chart, and they are not trained in the care of newborns. And there is some potential angst that we all have. Like, for example, they will do a tongue release to fix reflux. And they will do it if the kids have gas. They will do it if the kids are crying a lot. They will do it because there are breastfeeding problems, but they're doing it for other indications. And they're doing it sort of outside of this team. And so we've tried to say, we should be helping you. And if we need your services, we'd love to have you on the team. If you didn't charge $800 cash, but there was a discussion that we had about saying something in the clinical report about the dental scope of practice as to whether or not they should be taking care of reflux or crying in babies without being part of the medical team. And we didn't say that, but the dentists were among the loudest complainers about this particular clinical report.
Oh.
So it's worth knowing in your community if there are people who are doing this. They have high volume practices, and so the New York Times did a story about this as well, where there are sort of feedback loops where there'll be somebody out in the community that will do a feeding assessment who will refer to a dentist, who will then go back to the feeding assessment person, and sort of cutting out the pediatrician in the whole process. And it's one of the reasons I think that the ELF resolution came to light, was that these kids were going to get these procedures done without any contact between the pediatrician and the dentist, and without medical records, and really without it really knowing what the indication was for the procedure. And again, we're trying to say that there is a team around this family and that we can't operate in silos.
Absolutely.
And then we're very grateful that the dentist would like to do this, but they cannot. It's a lot of money when you go to see a dentist, which just can further compound it. Yeah, we did a Google search one day to see the sort of the general amount of money, and it was really $800 or more for them to do the procedure.
That's quite a bit. You're right. Medicine has to be a team sport. The primary care pediatrician, the pediatrician has to be involved. I didn't know any of that. That's absolutely fascinating. So the treatments we talked about, the laser, the clipping, the scissor clipper, and the old-fashioned one. And then there's no comparative data on lasers versus clipping in kids less than 6 months. And there's post-frenotomy stretching exercises, which some physical therapists will recommend, which are not recommended by you all and may cause oral aversion, which makes sense. It sounds painful. And then I didn't even know osteopathic manipulation. I learned more and more about that. It's been shown to be helpful for latching problems in breastfeeding newborns.
Sometimes. Sometimes. It hasn't been shown to be helpful in frenotomy. And so what'll happen is that the dentists will laser the tongue, and then they're worried that it's going to reattach.
I see.
They have a tendency to go pretty far back and just sort of eliminate the entire frenulum. But the tongue really only has to move about 6 or 7 millimeters. It doesn't have to be released. They will oftentimes just get rid of the entire frenulum. Also, there's a lot of people sort of stepping into the pediatric world who don't have any training in pediatrics. And they want the wound to heal by secondary intention. And I don't think we have a model for that where you go in and you disrupt a healing process. Anyway, we do know, though, if we do repeated painful procedures in the mouth of a newborn, that the newborn may decide not to use their mouth anymore. And I think we could have been of assistance, pediatricians in general, if we had been involved in some of the early frenotomies that were happening by laser. And I don't think we were. And so this has gotten to be a very common practice to go in and manipulate the wound. If the wound isn't as deep, and this is from Anna Meyer, who is the ENT that was on the clinical report, she says if you don't remove so much of the frenulum, then there isn't any reason to anticipate that it's going to scar down. And also, babies grow. And I think people who are in pediatrics know that babies will get bigger. And maybe that concern about how well the tongue is moving gets to be less important out of sight of the newborn period. But there aren't any studies done on it. And we just know from being pediatricians that repeated painful stimuli in the mouth may lead to oral aversion. And until we have better data, or any data really, that says it's necessary, that we shouldn't be recommending that at all.
Well, it added to my repertoire because we will sometimes get infants admitted with oral aversion. We don't know why it happened. Now we'll know as hospitalists to ask, was there a tongue tie release? Whom did it? And was there any manipulation done afterwards to at least give us an idea on perhaps how it developed?
Right.
But you talked about the research a little, and I want to bring that up because you talk about the research challenges a lot. And you all get into it quite a bit, that there are several small randomized trials of frenotomy, but you really talk about that these are a small number of studies, but each study, the studies in general, had a high number of methodological issues, including lack of well-conducted randomized controlled trials. So you don't have the proper evidence in the literature to really make any strong statements one way or another. Just because there's not some good studies done.
Randomized controlled trials, they're so frustrating to read. It's just so hard to read them. But one of them, they randomized the groups to a sham procedure or frenotomy. And these were people that were coming in to get their kids a frenotomy. And so that was the population that was studied. And they were randomized to a sham procedure or to frenotomy. And so they observed a feeding for 2 minutes. They took the kids off for either the sham procedure or the frenotomy, brought them back, had the babies feed again for 2 minutes without the family knowing whether or not the baby had the procedure. And in one of the studies, over 50% of the kids got better, and they still did the frenotomy on the control group. They did the frenotomy on the control group, and so lost any randomization and lost any follow-up. So they followed the kids for a couple of weeks, but by 2 minutes after it was done, they gave everybody the procedure. So we don't have any good data that we can even draw from that randomized controlled trial. So we just do not have any long-term follow-up. We don't even know what the natural history is of uncorrected ankyloglossia. There's just a lot that we don't know that makes writing a clinical report sort of challenging.
Do you know, are there studies in the books being conducted to help you get some of this information?
I think so. I don't know that. I don't know the answer to that.
Okay.
I would hope so.
Yeah, that part, it struck me that no one has followed up on the control group or the basically unaltered ankyloglossia in the natural state beyond 2 weeks of age to see what happens to those kids. Because I know
the kids, they were all offered frenotomy and they all took it.
And one of the things that wasn't discussed at all, this was a focus on ankyloglossia with breastfeeding. Did ankyloglossia and speech issues ever come up? I'm curious, in any of the meetings.
No, our remit was to do breastfeeding, but we also looked there was an ARC report that took a look at speech and did not find any compelling evidence. Again, there's a lot of flaws in the way that the data is collected. Obviously, we don't have a diagnosis. We don't have a validated scoring system, so it's hard to know. But there are kids who are getting frenotomies done for expressive speech delay, not just for articulation issues. They're getting it for expressive speech delay, which it's obviously not going to help, right? Getting a frenotomy to help somebody who has not spoken yet is not going to help, but that is There are a lot of indications out there that, especially on social media, where like I have seen in parents groups and tongue-tie groups, where the indications are things like oversupply, undersupply, gas, burping too much, not like being in the car seat. It's just foamy stools, not foamy stools, reflux. There's a lot of indications that could be a tongue tie. And a lot of the families on social media are saying, a kid will start spitting up and they'll say, well, has your baby been checked for ties? And I have a new grandson, which I highly
Congratulations.
recommend. Yeah, it's super fun. But my daughter-in-law was taking him for a walk in the park near their house, and he was crying. And a lady who she didn't know came up to her and said, does he cry all the time? Has he been checked for ties? And
oh, wow.
My daughter-in-law was just like, oh, lady, you have no idea. But,
yes, he has.
But it is a very, yeah. But it's just such a common thing now that when I see patients in my office, I say things like, I am checking for ties, so that like the family hears that I'm saying that and that I am looking at the frenulum, because any normal baby finding has now been sort of associated with tongue tie. And that is how you get exponential growth in the number of procedures that have been done. So,
well, anytime things in medicine get out of control, which does happen from time to time, the first step is redefining the topic and reorganizing what people know about it. And I do think that's what your report has done. It's reinforced what we know about the topic and really brought to light what we do not know, which is a fair bit. Review the definition, what we know, and then the anatomy, and then, of course, what we should look for, and then where next steps are. But it seems like an area ripe for research. I mean, it's looking for good, well-done studies on it.
Yeah.
And the only other thing we didn't talk about, you talked about buccal frenula are released by some physicians, but there's no evidence that that's helpful. And then posterior ankyloglossia, poorly defined term, lacked agreement, don't use it. And then everything's focused on the newborn period. There is a focus on the newborn period, but that's the bulk of what I wrote down. Did I miss anything?
No. I think what we've learned through all of this is that people really want to be successful at breastfeeding, that they really are looking for the help, and that they are finding it from unexpected quarters. And it is a very, very tempting thing to think, if my baby just undergoes this procedure, that breastfeeding is going to be easier for me. And it's sort of sold as sort of a magic answer. And it may not be. And we deserve to be better and loudmouth advocates for breastfeeding families, and to be better at our knowledge base for supporting them and learning what is happening in our communities with the services that are being offered to families, and that families really want to be successful, and we should, as pediatricians, really want to help them do that.
And I mean, for those of us like myself who work in a big academic center like Pittsburgh, that may be easy, right? We have lactation consultants, we have breastfeeding specialists, pediatric. First of all, if they're admitted to me in the hospital, I can bring everybody to see them. That's easy. For our colleagues and our practitioners in the community hospitals group, newborn medicine group, who are more in a rural community, I think what you're saying is that means finding out who the breastfeeding specialist is in your area. You have a patient where you don't think that the ankyloglossia is a concern, but you want someone to observe. Maybe the mother is having some breastfeeding issues. You've worked with her in the newborn nursery. Make sure you refer her to either that pediatric group that has the breastfeeding specialist, or the breastfeeding specialist if they have their own practice. That may be a better, from the beginning, get them involved and help the breastfeeding person really get better at this and have less pain for everybody.
Yeah, and just making sure too, if you're a newborn hospitalist, just making sure that there are people in the community that that families can call, right? So if families leave and there's still a concern that maybe there's a tongue tie, maybe there's not, that family needs to know how to get a hold of support in the community. And so it really, breastfeeding support just totally drops off from what happens inpatient to what happens outpatient, and making sure that there is some continuity there and that families know where they can go to get help. That's really important too. And I also, again, Dr. Bunick's system, where she involves a psychologist, we are, for better or worse, in charge of mom's mental health as well, until the OBs start seeing their patients a little bit sooner after delivery. And really paying attention to what's going on with her mental health is going to be important too, because some breastfeeding issues are related to, postpartum depression and other scenarios.
Yeah, having a screening for the mother is super critical.
Yeah.
Jenny, now I always give our guests the last word in terms of, is there anything we didn't talk about that you wanted to talk about?
No.
This was fantastic. I learned a lot from your guideline. I loved our conversation. I learned a lot from our conversation. I really can't thank you enough.
Yeah, you're welcome. You're welcome. It was fun. It's fun to talk about this. Now that it's over.
Now that it's over. The decade of your life. Well, if we have more of these topics, I'd love to have you back on. But thank you again for your time, and I can't thank you enough. And for those of you listening, thank you as well.
As a reminder, free CME is available, and it's courtesy of the University of Pittsburgh. Just click on the link under the podcast description and follow the instructions. Thank you to the UPMC Children's Hospital of Pittsburgh, and especially the Paul C. Gaffney Division of Pediatric Hospital Medicine.
Thank you again to our expert guest, and special thanks to all of you who take the time to join us. We know that your time is valuable, and we appreciate you sharing it with us.
Please feel free to email my dad at tony.tarchichi@chp.edu for any questions, comments, or podcast ideas.
As always, thank you for listening.